Hey mamas, welcome to another expert chat session. The topic for today's chat is Vbac, which is vaginal birth after cesarean delivery. So for today's session, I'm joined by the wonderful Dr. Poonam Arora, and we are chatting what is Vbac, what are some of the benefits and risks, what are the success rates, what can you do during your pregnancy to just improve on the chances of VBAC, and some tips on this topic from Dr. Arora. So I hope you enjoy the session. Thank you. Thank you, Dr. Poonam, for the previous session on C-sec births part 2. Let us chat more about another aspect, which is VBAC, and which is something that's very interesting. A lot of women want to take that route. Yeah. So would you like to tell us the definition, probably, what a VBAC is?
Yeah, sure. The term VBAC stands for vaginal birth after cesarean section, or another term which we use synonymous with the VBAC is trial of cesarean section scars. So that's the other term. So you might come across in some literature, if we say it says vaginal birth after cesarean section, and in the others it might be say trial of cesarean section, trial of vaginal birth after a cesarean section. So yeah, that's quite an sort of a informative topic as far as vaginal birth after cesarean section is concerned. Now, exactly how would you like me to base it, Ragini? I could.
Yeah. So, doctor, are there any success rates for women who go for VBAC after first cesarean or after 2 cesareans? So, are there any stats that you can share with us on this?
Yeah, sure. And see, the most important thing is that if you previously had a cesarean section at your first antenatal appointment, you can ask it in the first itself if you want. It is trial for vaginal birth is a shared decision which a woman makes with her obstetrician or her care provider. Yeah. In the early on in the pregnancy, or if you want to, it can be left to be discussed in the 3rd trimester later on. It is more based on a personal choice, and of course the previous birth experience can also influence a decision making, as far as the vaginal birth after cesarean section is concerned. And the other aspect you need to take into account is your future plans for other pregnancies. So some women might say, look, I'm just wanting to have 2 and I would be happy with another repeat cesarean section, but then circumstances can change, and your decisions can change as the time goes by. So a shared decision making with your care provider, whether it be an obstetrician or be a midwife who you would be wanting to see for your pregnancy care, would be the one who would be talking to you about. But of course you have to be under a medical team as far as if you are wanting to consider vaginal birth after cesarean section. Okay. Now, as far as the success rates are concerned, if you've had 1 cesarean section, the success rate is almost up to 60 to 70% reported in the literature. And if you've had 2 cesarean sections, even 2 cesarean sections, they don't prevent you from having a vaginal birth after 2 cesarean sections. The success rate goes up to somewhere between 40 to 50% based on what literature you are reviewing. So that's the success rate of a vaginal birth after cesarean section.
Okay. Because we have a few members going for a VBAC, I would really like to know what are the risks involved and what are the benefits, if you could just share that with us.
Yeah, sure. See, as I said, the most important, risks which we talk to the women, once they are considering a vaginal birth after cesarean section, is scar dehiscence. Scar dehiscence is that you've got a scar on the uterus, which is a weaker area. It can tend to, open up.
Yeah.
The risk of scar dehiscence is very minimal. It is 1 in 200. So look, I'm not talking about, in the percentages. What we are talking about is 1 in 200, which sounds an acceptable risk. It's not that we were wanting you to sound, but that is actually the true risk of having a scar give way if you had a previous cesarean section. Now, there's certain factors, it also depends upon what was the type of incision which was given in the uterine wall. So it is important to know the, details of the previous operative surgery to see what was the cut on the uterus. On the skin, the cut is always transverse. What is important is the cut on the uterus. Sometimes they can be a vertical cut or it can be a J-shaped cut.
Okay.
A vertical and a J-shaped cut is not suitable for a trial of vaginal birth after Caesar because of the risk of scar giving way quite easily.
Okay.
And the other is that if you've had any previous uterine surgeries, that means if you had a fibroid, which is a growth in the muscle of the uterus, you had a fibroid removed prior to falling pregnant, or you had a fibroid surgery, then that prevents you from trying for a vaginal birth because of the risk that the scar can give open. And if suppose by any chance you had a surgery and you did not know exactly what was the type of scar on the uterus, then in the ideal world we would recommend the women to say that, look, we are unsure of the type of cut you've had on the uterus. It's not the skin cut, it is the uterus cut which is important. We would recommend you to not try for vaginal birth, but at the end of the day, it's your choice. If you are quite convinced that that's what you would like to do, an unknown uterine incision is one of the relative contraindications for a trial of vaginal birth. That's why it's extremely important that from your previous obstetrician or from the previous surgical notes, you can definitely certain whether you are suitable for it or not. Your obstetrician would have told you first time after the birth that whether you are suitable for a vaginal birth after cesarean section or not. And if suppose any if it's a very big baby, and done serial scanning, then of course it's a sort of a relative consideration, but it doesn't mean that you can't try if it's a big baby. But of course, it's a relative sort of a consideration, and very close monitoring in labor is required in those situations. So these are the, sort of reasons which would prevent you from not having a trial of vaginal birth. And of course, as I mentioned before, it's all about you. It's all what you want to do.
Okay. Wonderful.
Of course, a decision to have a vaginal birth is entirely, the couple or the maternal choice, because she's the one who wants to feel empowered to make that decision. And then of course the role of your clinician would be to support you in whatever decision you make.
Yeah, I just had a question on the incision, doctor. That was a very good point, that from outside it might always look horizontal, but it's the uterus incision which might be a J-shaped or a vertical shape. So is that decided based on the positioning of the baby, like what kind of uterus incision is it, or why does it differ?
Yeah, it differs. So look, what really happens is when we do a cesarean section, that's a normal cut on the uterus. But sometimes, in emergency cesarean sections, we do find that the tissues are quite fragile and you've been in labor for a long time.
Yeah.
The incision, the cut, which was initially given like that can extend upwards or it can extend downwards, like instead of being like that, it can go up like that or it can go down like that. So that is a weaker point. So when it turns the incision from this to this or from this to this is a weak point, where the two lines are meeting. That increases the risk of scar giving open. That's why it is important. And of course, the vertical cut is never a strong, cut on the uterus, because it is a weaker cut which has been given vertically on the uterus. It is given more so if you had a preterm birth or if you had a difficult, position of the baby, which was a transverse position or oblique position. So in those situations, we might have to give a vertical cut, which is a weaker spot.
Oh, that's interesting.
And of course, the other important factor to consider in vaginal birth after cesarean section is the delivery interval between the two pregnancies. We generally tend to say that the interdelivery interval should be more than 18 months. So I would be comfortable to offer the couple to start trying after a year. But of course, by any chance, if it has if you've fallen pregnant, that doesn't prevent you from not continuing with the pregnancy. You can still continue with the pregnancy, but do understand that elective Caesar would be a good choice because the interval has been shorter. Or if you choose to have a vaginal birth, then of course understand that you have a higher risk of scar dehiscence.
Okay.
Scar dehiscence, scar giving open. Yeah.
Scar getting open. Okay.
Yeah.
Also, if a woman is going for Vbac on the day of the labor, how are things different to say versus a first delivery, which is most likely looking like a vaginal birth? So what extra care or what extra monitoring is going on in that room? Could you take us through that?
Yes, absolutely. So once you've had a previous cesarean section, so look, to increase the chances of you having a successful VBAC, the most important thing is that a woman who goes into spontaneous labor after the previous section has a highest chance of having a vaginal birth. So we do wait. We do wait till 40 weeks plus at times to give you a chance to go into labor. If by any chance you haven't gone into labor, it's not that you can't be induced. That means a labor can't be brought in. It can be brought in, but that reduces your chances of a successful vaginal birth.
Okay.
But so that's what you need to be, a bit be mindful of. That yes, these are the things which would improve or make it a little different. Now, once you come into labor, it's interesting. Once you are in labor, the risk of scar giving open is best determined by the baby's heartbeat. Because what happens is, as soon as the scar opens up, the blood flow through the placenta is completely, compromised. And the first thing that will become abnormal would be the baby's heartbeat. Okay. So that's why the baby's heartbeat needs to be monitored closely during labor. So you may find that vaginal birth is not a completely natural or unmonitored labor. It's a monitored labor very closely because we have to pick up the signs of scar giving open. And the first sign of scar giving open would be the change in the baby's heart rate. So that's why you would be hooked onto the machine, onto the machine, which we call as a CTG, which will monitor the baby's heartbeat throughout the labor. So that's how it would be different. You would still be allowed, you can mobilize, but then of course, as long as we can monitor the baby, we can listen to the baby and see how the baby's heartbeat is reacting in relation to the uterine contractions, which will help us to ascertain the baby's well-being.
Okay.
The maternal well-being is related to the fetal well-being because maternal scar opening up would be first evident in change in the heartbeat of the baby's
heartbeat. Yeah, wonderful.
So that's how it is different. And of course, as far as the pain relief options are concerned, they are entirely your choice. What options you would, take as far as that's concerned.
Okay. So, are all pain relief options available for a VBAC?
Absolutely.
Yeah. Okay.
Absolutely, all of them.
Okay. And what about induction? Is induction recommended for a VBAC, and what are the induction options for VBAC?
Yes, it's not, I wouldn't say it's recommended, it's optional that women can choose. I wouldn't say that I would recommend a induction of labor. As I said,
Sure.
we would wait longer than 40, wait up to even 40 weeks to go into labor. But of course, if the labor has not started, or at some point at 41 weeks plus, we would say that, look, the labor is not started. So your the doctor would do an internal examination to check what is your state of cervix. Is the cervix open or the cervix is closed? If the cervix is open, then breaking the waters and starting the hormone drip. These two things may be, enough to get you into labor. And then those progress of labor with continuous monitoring would help us to make the decision further. Now, if suppose your cervix is closed, it's not open, then the first step would be to open the cervix up. So that's my first step. I've opened the cervix up. The only method of induction which we use for opening the cervix is to use a balloon. So it's a small catheter, which it is very similar to what is put in the bladder to help us to drain the urine. It is a very thin catheter which we pass through the cervix and we, blow it up. So that balloon stretches the cervix with the help of mechanical stretch. And the following day, after 12 hours of having that balloon placed in, we can break the waters next day and start the hormone drip. So it's not contraindicated to give the hormone drip. The advantage of hormone drip is that it can be controlled. If we see that the uterus is contracting too much, we can stop it. But we can't give any other form of hormone in the form of a gel or in the form of a pessary of prostaglandin to bring the labor on.
Okay. So even with the hormone, is there the quantity that's limited versus a normal induction? Or
yes. I'd say it's not the quantity, it is the pace with which we increase it. We gradually increase it, and once you've started to get good contractions, 4 to 5 contractions in 10 minutes, then at times we need to stop it. So we've got to be very cautious. You have a very cautious and slow. So 2 terms I would say: cautious and slow. Use of oxytocin or a hormone drip would be the key to trial of vaginal birth.
Okay, awesome. And my the second last question, if that's okay, is what can women do to probably help their chances of VBAC?
So look, the most important thing is to, remain active, have a physical and, mental sort of preparation for it. Now, physical, of course, staying active, thinking positively would, increase your chances you would go into labor. But as I said, anxiety prevents you from going into labor. So I would say that focusing too much on it would also work in a sort of a little negative way. So thinking positive, staying active is the key to it, and waiting for it to go into spontaneous labor. If the baby is fine, if the baby's growth is appropriate, there is no concerns with the baby's well-being, waiting for the spontaneous labor would be the key to successful vaginal birth.
Okay.
But of course, only to an extent, not wait till 43 weeks or 42 weeks plus. 41 weeks is absolutely reasonable.
Okay. Great. So last question, doctor, do you have any tips for moms wanting to go VBAC? So what are your top tips?
So top tips, as I said, of course, the recovery is much faster patient satisfaction is the most important thing, and empowering the women to have a choice of what they want to do.
Okay.
It's absolutely fine, as I said, to choose an elective Caesar and to choose a Vbac. And being non-judgmental about what the woman chooses is the key to success of the mode of the birth she chooses.
Okay, that's wonderful. So try for it, but be open and don't judge yourselves. Don't judge
That's
others.
right. Don't be judgmental at all.
Yeah.
Be kind to yourself.
Yeah. So, doctor, what are the options available in the hospital? Say, for if a woman has opted for VBAC, but she tried and labored but couldn't go and had to go emergency C-section. So, what's the help that you get from hospital? Do they do like a debriefing or?
Oh yes, absolutely. As I said, after every emergency Caesar, you would always have a team which would come and debrief you. Even after a failed VBAC, your care provider would definitely come the following day, or sometimes women says, no, look, I'm not wanting to talk now. Debrief can be in straight away in the postnatal period, straight away after birth, or it can be done at 6 weeks. So debrief is extremely important, and if you think you would need some assistance as far as recovery from it, recovery from the experience is required, seeking professional help in the form of seeing a psychologist or psychiatrist is absolutely fine. It can be done straight away after birth.
Okay, yeah. So make sure you chat to someone, and if you're not feeling good, just speak to your midwife, OB, GP, whoever. Just talk to them. If there is anything stuck in your head and you feel like, no, I'm not feeling the best.
And so, look, I think it's only most of the time when things don't sit well or don't go well is when we have not discussed it. Yeah. So if we have talked about it, then it gives you an opportunity to move forward.
Yeah. Awesome. Thank you so much, Doctor.
You're
I think
welcome.
we have covered all the topics around
VBAC. Definitely. Yeah, of course. And thanks for giving me the opportunity.
Oh, it's such a pleasure to have you. Hey mamas, I really hope you got something valuable out of this chat. Don't forget to let me know in the comments how did you find it, whether it was good or you had any feedback so that we could do better next time. And if you have any questions for myself or Dr. Poonam Arora, do leave it in the comments below. Thank you so much. See you again soon. Bye.